This presentation will be prospective randomized controlled trial of traditional 4-port laparoscopic cholecystectomy versus single incision laparoscopic cholecystectomy. It's going to be presented by Dr. Melissa Phillips from the University Hospitals Case Medical Center, Cleveland, Ohio.
Thank you. Thank you very much for allowing me to present our information today. I enjoyed sitting at the awards luncheon and listening to Professor Pirasat as he won the Lifetime Achievement Award. And during his discussion, he was reminiscing back to 1989, where traditional cholecystectomy was an open operation. So I'm honored today to be able to present our intermediate results showing traditional 4-port laparoscopic cholecystectomy against single incision surgery. This study was sponsored by Covidien. There were 10 sites that participated, and these are listed for you here. Laparoscopic cholecystectomy was first described in 1985, and since that time it has become the standard of care for the treatment of biliary disease. Advantages offered by laparoscopic cholecystectomy include reduced recovery time, less postoperative pain, and improved cosmesis. As a trade-off for these advantages, there has been a small increase in biliary complications associated with this type of approach. Single incision surgery has been applied to many cases, including urology, gynecology, and general surgery. This was first described with regard to cholecystectomy by Dr. Navarra in 1995. Retrospective population studies indicate that single incision surgery may provide reduced pain and improved cosmesis. However, at this point, there had been no randomized controlled trials of single incision and laparoscopic approaches for comparison. The aim of our study was to assess safety, feasibility, and outcomes of single incision cholecystectomy versus standard 4-port laparoscopic cholecystectomy. We had 10 sites with a goal enrollment of 200 patients. Biliary colic was the main diagnosis with radiographic finding of either choledocholithiasis or polyps. Additionally, patients with the diagnosis of biliary dyskinesia and an ejection fraction less than 15% were able to participate. Patients were randomized in a 1.5 to 1 ratio. It is important to mention our exclusion criteria. These included acute cholecystitis, need for preoperative imaging of the common bile duct, current or previous repair of umbilical hernias, a BMI greater than 45, or age greater than 85. The single incision procedure involved eversion of the umbilicus and a 20-millimeter fascial incision. Through this, the Sills port by Covidien was inserted in standard technique. The 4-port approach included, at surgeon preference, either a 3- or 4-port standard laparoscopic cholecystectomy. A critical view was requested in all cases, and articulating instruments could be used by surgeon based on preference. Additionally, it was up to surgeon preference whether the performance of intraoperative cholangiogram was done. At the completion of the procedure, 5 cc's of 1% Marcaine were instilled at each incision, and steri-strips were placed in 4 standard locations, including the single incision arm, providing a single blind study arm. The primary endpoints were safety and feasibility, as well as outcomes, including all adverse events. Secondary endpoints included pain, analgesia use, quality of life, and cosmesis, measured using the body image questionnaire, photo series questionnaire, and modified Hollander scores. Our patient demographics included a total of 197 patients. 3 patients were randomized and chose not to participate before their operation. When looking at the 2 groups, there is no statistical difference between age or gender in our 2 arms. When looking at body mass index, however, there is a difference, with the single incision arm, despite randomization, having a mean of 29 and the 4-port arm a mean of 31. In assessing our operative details, blood loss between the 2 showed no difference. However, operative time showed a longer procedure in the single incision arm with a mean difference of 12 minutes. There was a single patient in the single incision arm that required conversion to 4-port cholecystectomy for inadequate visualization with a blood loss of 100 cc's. No patients participating in this study required conversion to an open incision. Again, these are our intermediate results. 84% of patients have had 3-month follow-up, but only 28% of our study population has completed the full 1 year in follow-up. When looking at adverse events at the bottom of the slide, the total number of adverse events between the two groups were equal, 34% in the 4-port approach, 38% in the single incision arm. However, when we start to look at subcategorizations of these adverse events, we find some interesting differences. Our wound complication rate in the single incision arm was elevated, 3% versus 10%. Important to mention, however, that none of these wound complications required opening of the incision or required admission for IV antibiotics. When we look at the postoperative hernia recurrence rates, there is no difference between the groups, 1.3% versus 3.4%. In each arm, there was a single patient with a retained common duct stone following cholecystectomy, and each were treated successfully with ERCP postoperatively. Additionally, there were no common duct injuries and no bile leaks present in our population. When assessing pain scores, the single incision group did have an elevated pain score based on a 10-point Likert scale. Looking at days 3 and 5, these are statistically significant, but there is less than a 1-point difference on a 10-point scale, and analgesic use between the two groups was equivalent. When assessing cosmesis, the single incision arm at all time points shows statistical favoring by patients. This is on a scale from 3 to 24, with higher scores being better. This was also confirmed in our photo series questionnaire, which was a self-ranking of the patient's own scar, subtracted as an internal control from a standard photograph of 4-port cholecystectomy. And again, at all time points, the photo series questionnaire favored single incision. When looking at quality of life, there was no difference in the mental quality of life between the two groups. The physical quality of life showed an increased quality of life in the 4-port cholecystectomy at days 3 and days 14. The explanation for this is still a little unclear. There are some limitations to our study. Specifically, there's a low rate of biliary complications in laparoscopic cholecystectomy, and despite a wonderful enrollment of 200 patients, this difference may be difficult to quantify. Additionally, our results may not be generalizable to patients with acute cholecystitis, as this was one of our exclusion criteria. We may also have a confounding variable in that the single incision arm had a lower body mass index despite randomization. Additionally, this study does not account for the learning curve associated with single incision surgery, as all surgeons participating in this trial had performed at least 10 single incision cholecystectomies prior to being able to enroll patients. And finally, these are intermediate results. The recruitment has been completed, but as shown earlier, only 28% of patients have completed their 1-year follow-up. In conclusion, 4-port laparoscopic cholecystectomy sets a very high gold standard for the treatment of biliary disease. It's an outpatient operation with a low morbidity and mortality profile. This study has shown the primary endpoints of safety and feasibility, showing that single incision cholecystectomy is technically feasible and does not, in our population, have an increased risk for biliary complications. Cosmesis is improved with single incision based on both the cosmesis scoring and photo series questionnaires. Single incision is associated with an increased risk of wound complications, although none of these were severe, added morbidity, required opening of the wound, or required admission for IV antibiotics. Pain scores were elevated in the single incision arm, possibly related to the larger incision size, but analgesic use was equivalent. And again, the clinical difference in 1 point on a 10-point scale in the pain difference remains to be determined. Additional follow-up is needed to clarify the long-term outcomes of single incision cholecystectomy, and we will continue to follow up the rest of the trial. And additionally, the role of single incision surgery in other surgical procedures, including urology, GYN, colorectal, and other surgical subspecialties, remains to be established. I'd be happy to take any questions.
Paper's open for discussion.
Randy Boyles, Jackson, Mississippi. We started lap chole very, very early, and I've personally done 5,600. And I want everyone to take this paper and recognize that this is data that tells you you don't have to jump on the single port bandwagon. I recently audited the last 150 patients that I did in my ambulatory surgery center, and here's the questions I'd like to pose to you.
Yes, sir.
Our mean OR time, my surgical time was 21 minutes mean and 22 median. Right. But more importantly, 150 in a row went home the same day. Well, how many years were same-day discharge? And the benchmark that I would offer to everyone here, which is probably more important than cosmesis, is how much total facility time do you use? And that is from the time the first incision to the time the patient goes out the door. In our series, it was 4 hours and 39 minutes. Finally, umbilical hernias are going to increase with time, and one umbilical hernia blows cosmesis to pieces. Thank you.
Thank you for your comments. All of these were performed as outpatient procedures. None of these required an inpatient admission. In terms of the operative time, again, multiple teaching institutions participated in trials. We definitely did have cases both in the 4-port and single incision arm that were in the 15-20 minute time range. We also had cases that were up multiple, 2 hours plus that were involved. And I think that range is partly institution dependent. It's partly, I think there's a learning curve associated with the procedure. But definitely the impact of time on both the financial aspects of cholecystectomy, as it's a very commonly performed procedure, as well as the time impact on patients under general anesthesia as potential complications has to be considered.
Michael Brunt, Washington University, St. Louis. Congratulations on carrying out a prospective randomized trial on this topic. I think it's very important for us to have this information. I have 2 questions. One is, you mentioned that the goal is to obtain the critical view, but did you actually go back and look as to whether there was any difference in to what extent surgeons verified that they got the critical view between the 2 approaches? And the second question is, was there any difference in the rate of cholangiography between the 2 groups?
The cholangiography, to answer that question first, is not as clearly documented. All of the single incision and 4-port arms performed at our institution did undergo cholangiography, and there's a poster downstairs for those interested in those results. I do not know the cholangiography results for other centers participating in the trial. In terms of the critical view, that was not assessed in terms of true documentation. It would be interesting to definitely go back through those operative notes and to compare that indeed critical views were obtained in all cases.
Min Lu from Rush in Chicago. Can you comment on the wide range of operative times that you reported? Is that a patient factor or a surgeon factor? And then also, can you comment on the involvement, the role of the residents in the case?
Absolutely. I think that the broad range of time is definitely all of those things involved. I think that patient factor as well as surgeon factor do contribute, and there are certain, again, surgeons that contributed patients to this trial who had a higher time than others when looking at individual sites. With regard to resident enrollment, again, I can't speak for all sites involved, but as the minimally invasive fellow, I was able to participate and perform most of those operations that occurred at our institution.
Andy Morfessis, Fayetteville. I think this is a very interesting study because you're really comparing 2 types of umbilical incisions, one which may be as small as 3 to 7 millimeters versus a larger one for your multi-port. And it'll be interesting to see how these patients do in the future and how many of them have umbilical complications or hernias.
Absolutely. At this point in time, we don't see a difference. There's a 1.3 versus 3.4% hernia recurrence rate, which is not statistical in this population, but there's a slightly higher number on one side. So we'll see how that sorts out when we get adequate follow-up at 1 year.
Rob Josloff, Abington, Pennsylvania. You cited an advantage of cosmesis for the single incision, which seems obvious, but I'm curious, in the 4-port technique that was used in multi-centers, where the extraction site was, many surgeons take it out at the umbilicus, but many also take it out in the subxiphoid region. Do you have a breakdown?
I do not. That would be an interesting thing to study, because if indeed the umbilicus is used as the extraction port, that could be a confounding variable on umbilical results.
Abdel Nimeri, Abu Dhabi. Congratulations on an excellent study.
Thank you.
Have you looked at the cost difference between the 2 procedures? Because in the single incision, you have to use the port.
Right. So published literature using standardly available instrumentation shows no difference between the 2. When looking at our institutional results, which did involve the use of commercially available ports, we showed a difference between 4-port laparoscopic cholecystectomy around $600 and single incision around $1,200, looking at a group of just under 100 patients.
Bernie Kempker, Jasper, Indiana. Was there a difference between your two groups regarding return to activities such as farming, factory labor, trucking, etc.?
I don't have that information to give you the answer. I apologize.
One last question from the floor.
Ali Tavakoli, Boston. Lovely presentation.
Thank you.
You show a very modest difference in wound satisfaction between the groups. Did you look to see if there was a sex difference between that satisfaction? Was the difference more marked in men or women rather than men?
No, not yet. We do have a multivariate analysis going that we're trying to get ready for the American College of Surgeons meeting in the fall. But until we get complete follow-up, those numbers are, again, a little bit subject to being intermediate results.
So, Melissa, that was terrific, and we look forward to your next paper on the 2-year follow-up on the umbilical hernia rate. So you've got everybody's imagination captured, the naysayers and those that will say it'll even out in the end. So we look forward to seeing you in the near future. Thank you very much.
Thank you.